blockers. Diazoxide also can be used very effectively. One must always remember the drugs contraindicated in pregnancy. Nitroprusside, strictly contraindicated. ACE inhibitors, receptor blockers are again contraindicated. Diuretics are relative contraindication. If you can monitor the hydration status of these patients well, you can probably use them. Target blood pressure is 130 to 150 even in patients who present with very severe hypertension, and 80 to 100 of diastolic. Well, at times when the patient first presents to you, one can take two paths. One is expectant path, where you are not very sure which way the clinical situation is going to take you, while on the other hand one must be very aggressive in managing the patients who present with eclampsia or preeclampsia or severe preeclampsia. One must not wait at all when you have one of these conditions. If the lady presents in shock, if there is a non-reassuring fetal testing, if there is a persistent severe hypertension which is unresponsive to medical therapy, there is a persistent headache or visual aberration or epigastric or right upper quadrant pain, eclampsia or pulmonary edema. So these are the conditions where one must not wait at all before initiating a quick treatment. And again, the presence of renal failure should desist you from taking the expectant management in severe preeclampsia. So the moment you find that if the serum creatinine has gone to more than 1 milligrams from the original baseline, or the urine output has not been more than 0.5 milligrams per kg per hour in the previous 2 hours, one must act early. If there is a rapid increase in the liver enzymes, or there is a progressive decrease in platelet count, something which alerts you towards the possibility of HELLP syndrome, which we'll be talking about in a short while, or if there is a possibility of abruptio placentae, and especially if the gestational age is more than 34 weeks, one must not delay the delivery. And HELLP syndrome again is an important thing. Well, quickly about eclampsia is obviously the more severe form. One has the lady gets to have one or more generalized convulsions. It can happen any time from second trimester to purpurium. The timing, it occurs very rarely before 20 weeks. 1/2 occur prior to term, while 1/5 occur before 31 weeks. 1/3 occur at term. 1/4 occur late postpartum, but within 4 weeks. So a normal delivery in a hypertensive lady does not mean that the risk of eclampsia has gone. The exact cause of causation of seizures in eclampsia is not known, but either it could be a cerebral vasospasm, whereby you have a cerebral overregulation, or you have a hypertensive encephalopathy where there is a loss of autoregulation which leads to hyperperfusion. So both cerebral underperfusion and cerebral hyperperfusion could be implicated as the pathogenesis. And the clinical manifestations are in the form of seizures, and of course the fetal also distress can be seen. Differential diagnosis in any patient of seizures always includes CVAs, hypertensive encephalopathy, SOLs in the brain, metabolic infection, epilepsy, pre-existent or some drugs. And the management includes the general, which means the airway protection, oxygen, control of convulsion. And here quite typically there is enough data to support that the use of IV magnesium sulfate in this setting probably has edges over benzodiazepine or phenytoin in controlling these infections. I think that those we can skip. And now coming on to the second form of hypertension which can present in association with pregnancy, and that is a chronic hypertension which always was there, continues during the pregnancy also, where the hypertension was detected even before the 20th week of pregnancy, and it persists for longer than 12 weeks postpartum. It could either be essential or it could be secondary. Well, what are the risks associated with pre-existent hypertension? It can get complicated with superimposed preeclampsia, with abruptio placentae, preterm birth, fetal growth restrictions, and the indications for treatment are that one must remember that the BP actually decreases during pregnancy. So even if you have a normal blood pressure or a little high blood pressure, that means the BP is really high, and the treatment of mild hypertension can at times prevent the possibility of the occurrence of severe hypertension later on. The other form which we what we can get as a complications it could either be a primary hypertension or it could be a secondary hypertension. That you will have to go into the details of the occurrence of blood pressure, and you will have to exclude the various causes of secondary hypertension which the lady may be having even before the pregnancy. Well, the third entity is a preeclampsia, which gets superimposed upon chronic hypertension. Well, the patient always had a chronic hypertension because of either essential hypertension or any of the secondary causes. Well, this pre-existent hypertension now gets complicated by proteinuria, which may not have been there, and this typically happens after 20 weeks of gestation. Women with pre-existent hypertension and proteinuria are considered pre-eclamptic in case of exacerbation of BP more than 110 millimeters diastolic in the last half of pregnancy, especially if it's associated with elevated liver enzymes or thrombocytopenia. Talking lastly about gestational hypertension. Now, this is a systolic blood pressure of more than 140 or a diastolic blood pressure of more than 90 millimeters mercury, which is not associated with proteinuria. And this also develops typically after the 20th week of gestation in women who were known to be normotensive before pregnancy. So what differentiates between preeclampsia and gestational is basically the occurrence of proteinuria. But at times, gestational hypertension, which typically presents towards the end of the last few weeks of pregnancy, at times can present during early course of pregnancy, especially in the 20th or 24th week of pregnancy, but is not associated with proteinuria. It resolves by 12 weeks postpartum, and the indications and choice of antihypertensive are same as those of preeclampsia. A few words about HELLP syndrome. Now, this is a separate entity, even though it's actually a severe form of preeclampsia. It's seen in 1 in 1,000 pregnancies, and 10 to 20% of severe preeclamptic patients have HELLP syndrome. HELLP actually stands for hemolysis, elevated liver enzymes, and low platelet. And the pathogenesis is probably is a severe variety of preeclampsia, but 15 to 20% of HELLP syndrome patients have no antecedent hypertension or proteinuria, and it comes like a bolt from the blue, and it's possibly caused by placenta-derived proteins such as CD95. It is clinically manifested as abdominal pain, tenderness, nausea, vomiting, malaise, hypertension, proteinuria, pulmonary edema, ascites. All those features which you see in preeclampsia are seen as in an exaggerated form in HELLP syndrome. The diagnosis is made by the presence of features of preeclampsia, the microangiopathic hemolytic anemia, the typical schistocytes, platelet count of less than 1 lakh, LDH more than 600, bilirubin just about normal or mildly elevated, but elevated liver enzymes. The differential diagnosis is from the acute fatty liver of pregnancy or thrombotic microangiopathy. The complications are quite bad at times, especially in the form of hepatic failure, hepatic infarction, hepatic hematoma on rupture, or it could be non-hepatic complications in the form of bleeding, pulmonary edema, renal insufficiency, at times severe enough to even warrant the need for dialysis, infection, and stroke. So it's a very important entity to be one really has to keep the possibility of HELLP syndrome in mind whenever one comes across a patient of preeclampsia. The management, of course, as in any other case of preeclampsia, is delivery, especially if pregnancy has already completed 34 weeks or there are non-reassuring tests of fetal status. or there is a presence of severe maternal disease in the form of multi-organ failure or DIC, liver infarction, renal failure, or abruptio placentae. So HELLP syndrome is very severe, and that is the reason why I have addressed it as a separate issue, even though it is actually a severe form of preeclampsia. Thank you very much.
Thank you very much, Dr. Khulla, for such a detailed and comprehensive presentation of pregnancy-induced hypertension and tackling the issue of pathogenesis and its management. In fact, during the presentation, I was just thinking, how come the nephrologist come in the picture of pregnancy-induced hypertension? I was under impression probably till the kidneys are fine, nephrologist is out. But since you have dealt with such a topic in such a detail, I believe candidates from OBS and gynae would have also benefited if they would have been listening. Just one issue which was coming to my mind is, can we predict preeclampsia?
This has actually been the main highlight of today's talk. You see, pregnancy-induced hypertension has been a very common entity all through these years. But the most important, the recent detection or understanding of molecules like SFLT1 and the soluble endoglin are the molecules which have tremendously improved our understanding of the concept of pregnancy or pathogenesis of pregnancy-induced hypertension. So these are the molecules which actually will help us to be able to predict preeclampsia. Now the clinical utility of these markers is not available as of today, but I'm sure in the times to come we will have tests based on SFLT1 and endoglin, which will help us to predict as to which particular lady is likely to have preeclampsia or eclampsia during the course of pregnancy. This is going to be very important, and as I have already mentioned during my talk, that this is something very recent. As the more just in the last couple of years we have started hearing about these molecules, and the matter of pride for the nation that an Indian has been associated with the discovery of these new molecules.
I think now the time is very less, but still I would like you to request, in fact I would request you kindly summarize the choice of antihypertensive with regards to a patient who is having a physiological stage of pregnancy.
Well, it's very important to use the correct kind of antihypertensives. So traditionally we rely very heavily on alpha methyl dopa for the control of blood pressure during pregnancy, because it's devoid of any significant side effects during pregnancy, both to the mother as well as to the fetus. Well, if alpha methyl dopa even in the maximal doses does not really help, then probably we can use a combined alpha beta blocker. We can use labetalol, and even if the two in combination cannot control the blood pressure well, then can we move on to drugs like calcium channel blockers, but preferably a sustained release of nifedipine. But more important is to remember that ACE inhibitors, receptor blockers are strictly contraindicated during pregnancy and even in lactating mothers.
Thank you very much, Dr. Khulla. I think we had a very interesting deliberation on this subject, and students would have benefited out of this interaction. We will close now and we'll come back again after a gap of 15 minutes to deal with another interesting topic, that is approach towards the patient. Thank you.